Good evening, ladies and gentlemen. I'm just giving another minute or so for people to join. Right, there's still some people joining, but I'm going to start so long. We are 2 minutes over the hour. Tonight's presentation will be by Engela Honey. Dr. Engela Honey is a pediatrician with an interest in children with genetic defects and has been working as a consultant and senior lecturer at the University of Pretoria since 1998. She finished the pre-graduate medical training in 1986 at the University of Pretoria and did a pediatric specialization at Stellenbosch University from 1989 to 1994. She worked as a pediatrician in the United Kingdom for a year before returning to the university in 1996, first in the pediatrics department, whereafter she moved over to university in Human Genetics Division of the Department of Biochemistry, Genetics and Microbiology. She sees patients referred from 2 academic hospitals affiliated with the university, Steve Biko Academic Hospital and Kalafong Hospital, where she teaches medical students from first year until their final year. Patients from rural hospitals in Gauteng, Limpopo and Mpumalanga are also referred to the genetic clinic held at Steve Biko Academic, George Mukari and Kalafong hospitals on a weekly basis. Outreach clinics are being held at Witbank and Tembisa hospitals every second month. Private pediatricians and gynecologists also refer patients to the department for genetic counseling, and she will see inpatients in private hospital where necessary. She is involved in the pre- and postgraduate training of medical doctors and other health specialists in the Faculty of Medicine, UP, as well as the pre-graduate and postgraduate training of genetic students in the faculty support groups for individuals with underlying genetic defects and developmental abnormalities. And Engela is going to present tonight for us a case study on one of the more common ultra-rare lysosomal storage disease, the diseases. So Engela, thank you very much, and I look very much forward to your presentation.
Thank you, Chris. Thank you very much for the invitation. And I'm feeling privileged to be part of this team of the inborn error of metabolism at the University of Northwest. I'm going to discuss an interesting patient, which I thought I've never going to see in my career, and eventually I did. So just with this ultra rare condition called alpha-mannosidosis was diagnosed in the 1960s, and then only here in the early 20s that they managed to find out where the specific gene is located. So it's a ultra rare or a rare lysosomal storage disorder, and due to a deficiency of acid alpha-mannosidase. The disease is cloned to the MAN2B1 gene on chromosome 19. Incidence depends on geographical location, but is estimated about 1 in 500,000 to 1 in a million. So you can see it is very rare. It has an autosomal recessive inheritance and a very wide spectrum of clinical findings and variability in its clinical presentation. This is quite a recent article based on South Asian populations, but it gives you a little bit of an indication on, it was derived from the Genome AD database, where they basically looked at the incidence. And you can see, and I'm sure it's not accurate, this is only cases that's been inserted into the database. But you can see in the Ashkenazi Jew population, it's very low. In Africa, not that low. In the South Asian, it's also quite low. In America's very, and the Latinos, very low. But you can see that we will eventually see cases in African populations. So let's go further to our patient. It was a little boy, 4 years and 2 months old at the presentation, was referred by a pediatric endocrinologist, gastroenterologist, due to the fact that he had deafness, presumed congenital deafness, symptoms of gastroesophageal reflux and fecal loading, and she saw that he had the subtle dysmorphic features. Previously, he had craniosynostosis, that is premature closure of the cranial sutures. So, very, very non-specific findings. The history, he was born after a normal pregnancy, was breech and had a cesarean section. His birth weight was 2.7 kilogram, and it was noted, I don't have the head circumference, that he had a very large head. He had hypoglycemia and was therefore admitted to the neonatal ICU. About the age of 3 to 4 months, his parents noted that he had an abnormal head shape and a craniosynostosis due to premature closure of the lambdoid sutures. Those are the sutures at the back of the head. There's no family history. His mom had a spontaneous miscarriage at 6 weeks. They unfortunately had to terminate the pregnancy for multiple congenital abnormalities at 20 weeks gestation. They have a normal 4-year-old son, and it was noted that there was no consanguinity. So if we look at the history, he had quite a few surgeries, inguinal hernia repair at 3 months. The craniosynostosis was corrected at 10 months of age, and he had repeated uh, uh, insertions of grommets and tonsillectomy and adenoidectomy. I understand he is going to go for reinsertion of the grommets in the near future. So he suffers from recurrent upper respiratory tract infections. The mom noted that there is some bouts of diarrhea. The gastroenterologist was considering overflow diarrhea from constipation, but that now in retrospect might not have been the case. He has speech delay, mostly, I think, due to his hearing deficit, and he received hearing aids at the age of 3 years. His motor development is only very mildly delayed, and mom and dad mentioned that his eyes are tearing most of the time. On examination, weight and height was below normal, but still within normal limits. But of note is that he had a very big head. It was 58 centimeters and well above the plus third standard deviation. I thought he had coarsened facial features, and of note on his skin he had multiple Mongolian spots, which we now understand can indicate a lysosomal storage disorder. On examination of his abdomen, he had a 4 to 5 centimeter hepatomegaly, but I couldn't feel a spleen. So during that consultation, I considered Hurler or Hunter syndrome, the mucopolysaccharidosis, and I was nearly sure he might have had Hunter syndrome. But obviously, the other storage disorders are also coming to mind, and I always want to exclude hypothyroidism. So I went ahead and did some further tests. the most, obvious test was his thyroid functions, and it worked completely normal. I did the urine uh, dry, sorry, total gags, which was only mildly elevated at 19.5 milligram per millimole creatinine. Normal is less than 12.7. It was noted that uh, glycoaminoglycans was abnormal, and heparin and dermatyl sulfate was noted. However, the lysosomal sixplex enzyme analysis came back completely normal, as well as the extended MPS panel, excluding all these common mucopolysaccharidoses, Krabbe's, Niebuhr-Pick, and Gaucher. I did also during that examination a skeletal survey, which supported the features of a mucopolysaccharidosis. So that was the way we were thinking. There was slight anterior listhesis, so that's where the one vertebral body slips over the other one, of T12 on L1, and then T10 to L4 had anterior vertebral beaking. This is called dysostosis multiplex. Obviously, that made us all a little bit confused, and as we had urine available, the metabolic lab did further oligosaccharide determination in the urine, and the urine TLC oligosaccharides actually indicated a abnormal oligosaccharide excretion pattern. And in the differential diagnosis was alpha-mannosidosis. So we were very fortunate that with the dry blood spot, the lab in Germany did the alpha-mannosidosis enzyme activity and gene sequencing of the MAN2B1 gene. And the patient was homozygous for this variant, uh, which was classified as class 5, basically because it was a null variant causing loss of function. There was very low frequencies in reference databases, but ClinVar classified it as pathogenic and was previously reported in the literature. I haven't looked at where it was reported, but it is a known cause for alpha-mannosidosis. So unfortunately, the patients didn't openly share photos of the little boy, so I just thought I'll put some photos from the literature. And if you look at the two boys, they are siblings in the top, figure 8. I don't know, apart from the broad forehead, that I would actually have thought there's something wrong with them. But gradually, you can see in the figure B that their features became more coarsened. And then in the adult at age 27, it is markedly coarsened. So this is progressive if there's no treatment available. And I think that gives you an idea why it is so important to make an early diagnosis. This is also photos from from resources online, and you can see, if I can share, there's that anterior beaking and the spondylolisthesis. Obviously, that was repaired. On this picture, you can see clearly the anterior beaking. Here, the coxarthrosis, so that joint is actually fused, and you can see the progression. So it's a progressive disorder. Here you can again, in this picture, see the abnormality in the vertebral bodies. And white matter changes on MRI. It can also present in adulthood, and there's different MRI findings. We haven't done an MRI, or I don't think we have done an MRI, in our patient as yet. It might be something that we need to do, but you get this white matter changes indicating dysmyelination, progressive cortical and cerebellar atrophy, a thin corpus callosum, and prominent Virchow-Robin spaces, and perioptic cerebrospinal spaces. T2 intensities in the basal ganglia, and that's indicated by the arrows here, is abnormal. Also in the cerebellum, the thalami, and in uh, the um, uh, the basal ganglia. So, what is alpha-mannosidosis? It's regarded as one of the glycoproteinosis, and it basically is a lack of one of the many enzymes for the sequential degradation of asparagine-linked oligosaccharides from glycoproteins in the lysosomes. These glycoproteins is then digested by proteinase and glucosidase to small fragments, which can either be secreted or transported to the cytosol for reuse. If this is inadequate, you get accumulation of oligosaccharides and glycoproteins in the lysosome, which will influence cellular function and eventually cause apoptosis. This is just a cartoon explaining that alpha-mannosidosis is supposed to cut the glycoproteins, and in the absence, you get basically a accumulation of the alpha-mannosidosis in the lysosome. As I mentioned, it is due to a defect in the MAN2B1 gene located on chromosome 19p1313. In the bottom graph, you can see the normal lysosome and then this vacuolated or the normal lymphocytes, and here vacuolated lymphocytes in normal controls. So the clinical presentation, as I mentioned, is very variable and can be either type 1, type 2, or type 3. Type 1 is the mild form, and clinical features usually only start after 10 years of age. They don't have the severe central nervous or respiratory infections. They are weak, they have myopathy. It progresses slowly, and there's no skeletal abnormalities. In the type 2, the moderate form, and I think my patient is most likely in the moderate form, is before the age of 10 years. The myopathy, it's also slow progression, but now we have the presence of skeletal abnormalities. The type 3, the severe form, has a very early progression that leads to early death and severe uh, involvement of the central nervous system and severe infections. I'm still in doubt if our patient is between 2 and 3. I hope he's actually the moderate form. So just a little bit of idea of, you can see that it is a multi-system disorder. And here you can see in the brain, you can get brain changes. You get a learning disability, can be mild or more severe. And obviously, due uh, to the hearing deficit, there can be difficulty in speaking. Hearing loss, about all patients will have hearing loss, and it can be conductive or sensorineural. Coarse facial features can have a polyarthropathy where multiple joints is affected, have some skeletal abnormalities like scoliosis or uh, what we call the gibbous. It's where there is this curvature in the spine. There's increased risk for infection with immunodeficiency and autoimmunity. There has been numerous cases described where it's associated with systemic lupus erythematosus, SLE. Motor control, they appear to be clumsy. It can cause muscle weakness and joint abnormalities. So, as you can see, multi system involvement. The core clinical features will be the following: a big head, which our patient do have, prominent forehead, high arched eyebrows, a depressed nasal bridge, wide spaced teeth, a big tongue, and a jaw protruding forward, prognatism. Hearing loss is, as I said, invariably present. Frequent infections, especially in the type 1 or type 2, or the type 2 or type 3. Developmental delay and intellectual disability, which can be variable, and ataxia. So that was, I think, if I look now in retrospect, about all of the features in my patient, except the ataxia, which is usually quite late onset, was present, except maybe the macroglossia. So it's always easy to put down back the retrospective scope. And I am, now would most probably be more triggered to make the diagnosis in future patients. So the features is a continuum, and in the first decade, they do have this recurrent infections, most commonly pneumonia, gastroenteritis, urinary tract infections, or otitis media. So that would be your early presentation. In the second and third decade, it's mostly ataxia and muscular weakness. It seems like the risk for recurrent infections subside, and then you basically get more of the neurological features in later life. Other features, there's definitely a decreased antibody response to vaccinations and illnesses. As I mentioned, there's an increased risk for autoimmunity, and there's been cases described with systemic lupus erythematosus. Intellectual disability is usually mild to moderate, but IQ between 60 and 80. And although there's not many cases to compare, they have, conflicting, reports if cognitive ability decline with age. Neurologically, very often seen that patients have a communicating hydrocephalus, can be having spastic paraplegia or ataxia. In adults, very often behavioral, there's a speller, psychiatric abnormalities, to even to the extent of psychosis, delirium, and anxiety, and usually after a physical or psychological stressor. That means, there was some, incident that either cause illness or emotional distress. They can have hip pathology and gyno valgum. So that would influence the knees with basically knock knees. Gastrointestinal, increased frequency of bowel movement, sometimes severe difficulty with feeding, necessitating a gastrostomy, and hepatomegaly. Interesting, they don't mention splenomegaly so often. They can have optic nerve atrophy or what they call tapeto retinal degeneration. And the heart, some valvular lesions, stenosis and regurgitation of the aorta and the mitral valve, and even a dilated cardiomyopathy. And that usually only presents in adults. They can have abnormal lung function tests too, so multisystemic involvement. Prognosis, I went and had a look, and it does actually cause a reduced lifespan. And the mean age of death in most of the studies is about 40 to 45 years of age. And they've looked at the cause for death in a study in 15 individuals, and mostly pneumonia and cancer. Cancer, not always sure if it's related to the condition, but obviously a lot of these causes for death was due to complications. Uh, Acute renal failure due to intestinal perforation, kidney failure, heart failure, and dehydration. Eventually, a lot of these individuals will become bedridden and then obviously will have a very poor quality of life. So you can see a lot of these features are so non-specific. So in this very recent article, they actually gave a little bit of a flow diagram if you want to make the diagnosis. And they actually state that in the case of A is individuals less than 10 years of age, if you have speech delay and hearing impairment and you have two or more of the following features: cognitive delay, motor disturbance or impaired balance, and facial features, which is usually milder than your mucopolysaccharidosis, you should actually refer to an expert metabolic center because that can be alpha-mannosidosis. In individuals older than 10 years, you can actually look at motor impairment, mental retardation and regression, and psychiatric manifestations, including psychotic events. If it's present and there's a hearing impairment and an intellectual disability, motor disturbance, and skeletal disorders or joint disease, you should also refer to a metabolic center. So that will most probably increase the diagnosis of this condition because early diagnosis matter. So what can we do to diagnose alpha-mannosidosis? You can do and identify a deficiency of this enzyme in acid alpha-mannosidosis in leukocytes. You can also look at the genetics and look for biallelic pathogenic variants in the gene. So your testing options, this is in the Gene Reviews article, would first be to do single gene testing. I am not completely sure, but I suspect we did single gene testing. And can look for nonsense, missense, and splice site variants and small insertions or deletions, followed by targeted, if negative, by targeted gene deletion duplication analysis. Or you can also do a multi-gene panel, which include MAN2B1. So it's usually a lysosomal storage disease panel would include this gene. Option 2 would be, if you are not sure, is to do more comprehensive genomic testing like exome or genome sequencing. Sequencing analysis will pick up about 95.8% of the variants and targeted deletion duplication less than 2%. So if you do a multi-gene panel, you will most probably have a good coverage to detect the variant. Management, there's general supportive care. You will monitor the growth, look for the hearing, immunology for frequent infections. If there's signs and symptoms of systemic lupus erythematosus, you will refer to a rheumatologist, developmental assessment, neuropsychiatric evaluation. Look for communicating hydrocephalus. That can happen at any time during life. And look for gait and abnormalities and ataxia. In the young child, and even in the adult, you can do occupational and physiotherapy, plain x-rays for lytic both lesions, and then referral to other specialists to detect eye, respiratory, and cardiovascular abnormalities. It's autosomal recessive, so you do have to send your patient for genetic counseling. I do genetic counseling, although I'm not qualified as a genetic counselor. And in cases of autosomal recessive inheritance, both parents will be carriers, and there will be a 1 in 4 chance of an affected individual. So that would be very important to basically, determine recurrence risk. Our patients' parents are not that keen to have them tested. I offered it to them because they say they're not going to most probably have further children, but I told them they can come back because they recommend that you actually do test the parents to confirm that they are both carriers. So heterozygous carriers are asymptomatic and not at all at risk of developing the disorder. However, other children, you will have either a 25% risk to be affected, 50% risk to be a carrier, and a 50% being unaffected. So eventually, they recommend that you should actually test all the SIPs of the proband. I haven't tested the 4-year-old other child. That still needs to be done. If the variant is identified, you can do carrier testing for other family members, like the parents, brothers, and sisters, if they want to determine if they are carriers or not. But to remember that they will only be at risk of an affected child if their partner is also a carrier. I don't think I have any idea what is the carrier rate in South Africa. In fact, I've only managed to find another article presented by the University of KwaZulu-Natal of 2 boys, but they didn't do genetic testing. They just described the clinical features. Prof. Foster can maybe tell us if there's any other patients that they identified, but I'm not sure. I actually think this is the first case described in South Africa. Prenatal testing and pre-implantation genetic testing will be possible if the variant is identified. So general supportive care is continuous, but recently we have had the possibility to make use of targeted therapies. And the 2 major therapies is enzyme replacement therapy or hematopoietic stem cell transplantation. So enzyme replacement therapy is now kind of the standard of care. It's valmanase alpha, and the dose is 1 milligram per kilogram, IV infusion once a week. The advantages is it will change the biochemical and functional parameters, but it unfortunately have no effect on the central nervous system uh, features of alpha-mannosidosis. So it's not going to change any central nervous system, abnormalities. Hematopoietic stem cell transplantation has been used longer, so there's better monitoring and better data on the effect. And it's for severe cases with variable outcomes and survival rates. I am going to contrast the two with regard to price and outcome in the next slide. There is research studies ongoing regarding gene therapy, but I couldn't find any that has really gone into human, research in the literature. Now, in our patient, the family is more in favor of hematopoietic stem cell transplantation because they think it is a once off, and they did extensive research themselves. I am not sure, but I'm surely going to see, what is feasible in our family. So we basically have, enzyme replacement therapy and hematopoietic stem cell therapy for the treatment. So, in contrast, these two, enzyme replacement therapy is very expensive. A 10 milligram vial cost 1,522 euros 60 cents. I am not 100% sure it's available in South Africa, but some of the websites says it has been approved by SAPRA. Although AI, if you do different searches, it gives conflicting results. In the case of hematopoietic stem cell therapy, it's also very expensive, can be more than R1 million. But the problem is it depends on if you can get a compatible bone marrow donor. As mentioned, enzyme replacement therapy has an improvement in the biochemical and functional parameters. So it does help with hearing, motor function, and decrease the risk for infection. If you can give hematopoietic stem cell therapy early on, it actually has a good effect on hearing and development. Enzyme replacement therapy is well tolerated. It's now the standard care. In the case of hematopoietic stem cell therapy, there is risk for transplant-related complications. But in a study done on individuals, the survival rate was 88% at 5.5 years post-transplant. It can halt the cognitive decline, but however, very variable results was documented. There's now a registry where they're trying to assess what is the outcome of both these therapies. Supportive care in some cases is also recommended as the only if there's no other available. And as I say, with supportive care, patients can actually survive till their late 30s, 40 years of age. So resources, there's many resources, even though it's such a rare condition. They have started a registry called the Sparkle Registry, where they're looking at the outcome of patients in all three of the legs. Only supportive care, stem cell enzyme replacement therapy, and stem cell transplant. There is a website. It's the International Society for Mannosidosis and Related Disorders, ISMRD, and that is a very good resource for parents to go and have a look at. The enzyme replacement therapy, has its own resources that the patient can look at. And then the National Organization for Rare Disease has also got a support group for alpha-mannosidosis. So you can refer your patients to these organizations. I am not sure if we at the Rare Disease South Africa has a registry or have any cases described with alpha-mannosidosis. So this is my references. I mostly use gene reviews. Uh, the groundbreaking article from Malm and Neeson was published in 2008 already, where they already have identified the gene and started with enzyme replacement therapy, discussing of that. This article in the Journal of Child Neurology was the article published in KwaZulu-Natal in the two cases. And then a very recent article is where I got the table for the practical approach to reduce the diagnostic delays. That would be an article if you really want to go and have a look at, how can we shorten this. I also just had a look and I see Dr. Chris Hendricks, Prof. Chris Hendricks, was a co-author on an article on a registry that was published in the United Kingdom. So it's not that rare. I think we should actually call it, the zebra. We should look out for it. And that is what I want to say. Thank you for listening. And if there's any questions, I can answer
that. Thank you, Engela. Fascinating case. This is one of those rare occasions where there is actually already a question. And the question is from none other than Chris Hendricks. He is asking, have you measured IgG in this patient, as they frequently have low levels and benefit from IgG infusions or prophylactic antibiotics in winter months pending availability?
Thank you, Chris. I am not the attending pediatrician. It's Dr. Alter Blanche, and with the recurrent infection, she might have done it, but I think it is a good suggestion. As I mentioned, the recurrent infections, and as I understand, he's going in for surgery, if it's not already, to again replace his middle ear tubes. So I think that is a very good suggestion. I didn't know before I prepared this talk that this is an important parameter that we need to monitor.
Okay, right. Colleagues, if you have questions, please post them in the question and answer section while we're waiting for some more questions. Engela, I think there's a
I'm going to unscreen. Chris, I stop
process
share.
requests the sixplex or the expanded sixplex LSD, sometimes also the glycosaminoglycans, but you actually need to request the oligosaccharides as well. That's, well, the first line that we have in South Africa. So clinically speaking, what would be those clinical features that would make you think, okay, this is not mucopolysaccharidosis, this may be alpha-mannosidosis?
Chris, I can't answer that question. As I mentioned, I definitely thought this was a mucopolysaccharidosis. Uh, as I mentioned in the talk, the features are very subtle and less obvious than in the case of a mucopolysaccharidosis. I think the hearing loss is most probably a clue to basically prompt that you should look at alpha-mannosidosis. But as I say, common things occur more commonly, so I would definitely first consider mucopolysaccharidosis before I will consider alpha-mannosidosis. But I think this was a learning curve for us also, that if you have clear clinical features of a storage disorder, you should not stop by only looking at your mucopolysaccharidosis. You should go and look further, your lipidosis and other storage disorders. So I think in that case, endeavor in your NQE program is going to be very helpful, that it will give us opportunity to look further in those undiagnosed cases with very rare disorders.
Thank you. Chris?
Yeah, just to comment on that, I think a really important comment is when I see a patient that looks like an MPS, but all the test comes back negative, the next thing I do is I look for a microdeletion if it's not been done, because I've seen many patients which I thought had MPS and then had a small microdeletion. And once that comes back, I would look for the oligos and just get them sent off, because that's where you frequently get your misdiagnosis for the oligosaccharide disorders.
Oh, that's very good
I have
advice.
a question for Prof. Hendricks.
Yeah.
So this is the first case that I described. In those cases that you described in the UK, I see, if I remember correctly, the youngest was, I think, 7 years old. And then you saw cases of people in their 30s. How fast was the progression of the disorder in those cases?
Well, they're two different entities. So the first thing is that the older patients was quite interesting because they presented with ataxia, and we diagnosed them as students. They were both at university. So their mental disability was not that bad. Actually, doesn't say a lot about our universities, but I won't go there. But they were at university, and actually they were picked up because of ataxia. They were falling down the stairs all the time. So that's what the older ones. The younger ones, which is interesting and brings back to another issue as well, is that we had two siblings and they were 2 years apart. And we actually transplanted the older sibling first. And because he had such a good response, the family asked us to then transplant the younger sibling, different to what you would normally think. But because he was so advanced and the family was actually medical doctors, they said, let's do the older child first. If it's not a good outcome, it can't be worse than what he is. So at the age of 9, he was quite significantly disabled already, both physically and mentally, which is why they came to their decision. But because he then regained some of his mental disability, actually made progress, and his joint disease kind of became static, they thought it was a great idea. So we then actually transplanted the younger sibling as well. So those are the two things. So the progression is relatively slow in most of the patients, which is one of the difficult decisions when you were talking about HSCT. The donor is no longer a problem. We've got a huge cord cell bank now in Europe and the US. So finding a donor is not the issue. The issue is, who do you get them to transplant? And that's my concern when I hear many of these in Africa, is that most of the people offering transplantation in India and places like that does not have the PK abilities to actually do busulfan PK. And that hugely influences the mortality and the morbidity. So when you don't have busulfan PK, your mortality increases by 10% and your morbidity by 15%. So by default, you have to send them to expert centers. And then to some extent, you lose some of the cost benefits. So if you're looking at transplantation in the UK, you look at about 3 million is the UK, which we quote outside people in general, more or less. And in the US, you can multiply that by 5. We look between 10 and 15 million is the cost for HSCT. And it's purely because this PK is so expensive to do, but it increases the things. So it's just one thing. If people go into transplantation, I'm not against it. I just say pick somebody who can actually do the PK, or be honest about the risks. If they can't do PK, just remember mortality increased by about 10%, morbidity about 15%. You then start looking at 50-50 outcomes, which is not brilliant, which is why enzyme has become the kind of standard of care, but it is a cost issue. That's the big issue.
And it's lifelong, and that, I think, is what worry the family. They're both professionals, and they obviously went and read the literature in detail.
Yeah.
So that is still a debate that I have. I was wondering, maybe I can refer the family to you for just a discussion of the two entities. But I have referred them to the local hematology oncology team here at University of Pretoria. and but I haven't taken up the offer as far as I understand. But that I might be different because the father is not currently in South Africa. He's working abroad. So, and the little boy is not well, he has this recurrent infections. So, in those cases, I see the article was in 2018. And I just noted that you were from the University of Pretoria at
Yeah.
that stage. But when I went into the article, I thought maybe you described a South African case, but I see it was only UK cases. So was any of those started on enzyme replacement therapy, and what was their outcome?
It becomes more complex. So some of those patients went into the clinical trial, and the majority of the patients on the clinical trial was actually from Finland. I actually would have seen from the prevalences because there's a much higher frequency in Finland. So that's where and the original primary outcomes of the clinical trial was actually not met. So it showed variable response, and it's because exactly the heterogeneity so different between the different patients. And then also the fact that the disease progression is slow and the clinical trials are short. So what we did is we did a reanalysis of all the data by using O'Brien statistics, where you actually allocate them in different domains. And that actually got it approved in the FDA only last year. It was only approved in the FDA last year. It's been in Europe longer. And it's purely because that benefit is so variable. So again, patients for enzyme replacement therapy, they need to understand it is lifelong, it is expensive, it is invasive, it's once a week. So it's not an easy choice. And sometimes not treating is a better choice. And I think I like it. And that's why I say I'm not against any of the treatments and I've got no bias. I just need patients to have all the right information to make an informed decision of what it is. And some situations are better than others. I think if you're in a high income country like the UK, where you get all of your medications paid for, you get all your home care, all of those things, I can see why enzyme replacement therapy is standard of care, because you wouldn't be allowed, ethics would kick against that mortality. 10 to 15% mortality would just not be acceptable. So that's why it is except for exceptional cases. So but it's individual, and I think that's the really important thing. It's an individual case to decide. And as always, I'm very happy to talk to families as long as they know that I'm no longer registered to practice because I've retired, but I'm very happy to share my expertise of what I've learned over the years and what just to put it in perspective, what is the best outcomes. And exactly what I said earlier, there are some common things you can do. If you don't have IG infusions or it's too expensive, you can't get them at home. We use azithromycin mostly 3 times a week for prophylaxis during the winter months. And for those who can't afford it, we use trimethoprim old-fashioned. But there is different ways to improve quality of life without expensive treatments.
And have you ever, sorry, I'm hijacking you because I have another question, but then have you had cases where they did stem cell transplant and then because the enzyme uh, level didn't go up and they after did enzyme replacement therapy on the same patient?
So no, not in alpha-mannosidosis. We've had it in some of the other MPS disorders, which of course is a different category. So we've seen that in MPS 6 is most probably the best described. And again, it's patients who get, what we do know is none of the treatments, neither enzyme replacement or hematopoietic stem cell, is very good at managing bone disease once it's fixed. So you need to try and treat it before your bone disease is fixed. That's why the younger age becomes so important. And with your enzyme treatments, you get improvement of joint range of movements, but you don't get improving bone. And with the Alpha-man, they're particularly susceptible to hip osteomyelitis. So you frequently see them with the osteomyelitis of the hip and losing a hip. And that's why the infection prevention is such an important thing and why people do treat, especially the younger kids, with their enzyme replacement therapy, because a hip replacement is quite an impact on your quality of life long term.
Okay, now thank you very much. Any further questions?
Yeah, okay. Colleagues, I see there's no further questions. Maybe just as a side note from my side, this is also our first case of alpha-mannosidosis that we saw in the laboratory. We have seen quite a few cases through the European proficiency testing program, so I think that's why we were able to make it. It was in our minds because we've got a few cases through that. But again, you know, it comes down to if you don't think about it, you're not going to diagnose it. And hopefully your presentation is going to help us all just to think about alpha-mannosidosis when we encounter patients suspected with an MPS disorder. So Engela, thank you very much for your presentation. It was really fascinating. I'd also just like to thank Sanofi for sponsoring this series of CPD presentations. And just again to assure you that Sanofi has got no influence over the content of the presentations or the presentations that are selected. So I hope this presentation was as good for you as it was for me. I wish you a pleasant evening, and then we'll see you next time. Goodbye.
Thank you very much. And thank you for the invitation again.
Thank you, Engela.
Okay.